Going to go over needle chest decompression. Needle chest decompression is a procedure that's performed to manage tension pneumothorax. It's indicated in traumatic cardiac arrest as well as primary spontaneous tension pneumothorax. And also it can be indicated in patients that are trapped with respiratory distress as well. Needle chest decompression is viewed as a life-saving procedure, but it doesn't completely correct a tension pneumothorax. It's perceived as being a procedure that prevents the worsening of the tension pneumothorax rather than completely resolving it and potentially returning some cardiopulmonary function. To perform it, we're going to first need to identify that it needs to be done. So the signs and symptoms that we're going to be looking for a needle chest decompression is that of a tension pneumothorax, which is going to be an increased respiratory rate, decreased oxygen saturations. The probably more specific symptoms would be decreased chest sounds on the affected side, and obviously combined with some obvious trauma on that side would help as well. You may feel some asymmetry of the chest on respiration, and you may also notice some increased jugular venous distension present, which may not occur in the hypovolemic patient. Tracheal deviation is often quoted as another sign and symptom, however that is an extremely late phase symptom and may not ever be evident at all. You may also have hypotension, tachycardia and a loss of a radial pulse. Assuming those conditions have been met, we will need to perform this procedure. To do so, we need to find the correct anatomical position. There's a mixture of ways of performing it. The two most common would be by inserting the cannula in the second intercostal space at the mid-clavicular line. However, recent case reports and research have shown that also a more lateral approach at the fifth intercostal line on the mid-axillar line is also quite successful and may even be more successful than the anterior approach. Prior to insertion, we need to confirm the anatomy and the location is correct with another clinician. We're going to identify the clavicle. I might do it this way because it's a bit easy to see. So identify the clavicle and taking an appreciation of the full length of the clavicle and the mid-clavicular line, which should be about here. We're also then going to palpate down to find the second intercostal space and mark it. I'm going to confirm that location with another practitioner and then prepare the 12 cath. In SA ambulance we use a 12 gauge 12 cath, which is I think about 9 centimetres long. We're going to clean the site and perform the puncture on that marked spot, and then once we've got it probably almost to the heel, we're then going to remove the sharp. Doesn't want to come out. Okay. Remove the sharp and place it in the sharps container. Now, you may hear a hiss or a pop in a very quiet environment, but that the lack of hiss or pop doesn't mean that it hasn't worked. You may see an improvement in the presentation of the patient. If you don't see any improvement in the symptoms that we described before, you can perform the procedure, moving in a lateral direction, or also moving to that other site at the fifth intercostal space. So the advantages of needle chest decompression are that it is relatively quick to perform and it's relatively simple to perform. However, it does have a number of drawbacks, one being that it doesn't, again like we described before, it doesn't completely resolve the situation, and it also can give clinicians on scene a red herring that the chest issue or the tension pneumothorax has been addressed and completely resolved. There is also, depending on the approach used, the experience of the provider and the equipment used, a fairly high failure rate for the procedure, and that's usually due to not penetrating the chest wall deep enough. So most of the time this will require advancing to a finger thoracostomy and or a chest tube insertion, even if the decompression is successful.